Well, related to heart failure, there were, again, several studies shown in London, and there were 3 attempts to see whether it is possible to improve left ventricular remodeling. As you know, in cardiology, we have been very successful to reduce mortality from myocardial infarction from 20% to almost 5%, but that is causing a lot of heart failure and a lot of remodeling of the ventricle. Therefore, reducing remodeling is an important topic. And in London, there was the attempt to reduce remodeling by pacing the left ventricle, not with the CRT, but with just a normal pacing. And this was called the PROMPT trial. And also there was the idea to try to use a new way of anti-aldosterone drug, and that was called the Albatross trial. And also to use cyclosporine in order to block the calcium POA, which is considered to be one of the possible cause of remodeling. Now, going to the PROMPT trial, in 3 years between 2010 and 2013, 126 patients were randomized, and they were randomized either to receive left ventricular and right ventricular pacing, or just left ventricular pacing, or no implantation at all. As you can see, it's not a large trial with just a few patients in each arm. Some of them were able to complete the study, and unfortunately, as you can see, there was absolutely no difference in any of this group in terms of improvement of left ventricular function at 18 months, suggesting that pacing the ventricle is not really important. This is just pacing the ventricle, is not resynchronizing the ventricle, which is a completely different story. Then, as for the Albatross trial, after an acute myocardial infarction, in the first 72 hours, patients were randomized to the controlled best possible therapy or to aldosterone blockade, which was done by intravenous potassium cannonate followed by spironolactone. These were the combined endpoints, which has included almost everything, and this was looked after 6 months from initiation of the therapy. And once again, as you can see, this new mineral anti-aldosterone regimen was not able to modify at all the prognosis of these patients at 6 months. So once again, a neutral kind of trial. And also neutral was the Circus trial, because cyclosporine was not able to improve the primary endpoint of the study. Just to stay, the only good thing in the Albatross trial was that there was a reduction of mortality for STEMI. Then just to stay with anti-aldosterone therapy, in London was presented the results of the ARTS heart failure trial. And this trial was looking at finerenone versus eplerenone in patients with worsening chronic heart failure and diabetes or chronic kidney disease. The rationale to use finerenone, which is a new compound produced by Bayer, is that this new compound has greater receptor selectivity than spironolactone and better receptor affinity than eplerenone, at least in vitro. So this is just a slight modification of the usual anti-aldosterone drug with better receptor selectivity and affinity. And the study was to compare the safety and efficacy of different doses of finerenone, and the comparator was eplerenone in patients who presented in the emergency department with worsening heart failure of reduced ejection fraction, with type 2 diabetes and chronic kidney disease. So we are talking about really very severe patients with several comorbidity. The study was a sort of a dose-finding study, looking at, there was a control group and several groups receiving increasing doses of finerenone up to 50 to 20 milligram. And these are the results. As you can see, the primary endpoint was not met in any of this group with any of this increasing dose. Not only that, but also there was no changes in death from any cause, cardiovascular hospitalization, or just worsening of heart failure. And probably, I do not know, but the further research from this new anti-aldosterone drug will not continue. Then there was another interesting trial, the so-called benefit trial, looking at benzidazole and as a possible drug able to interrupt the trypanosomiasis. Well, this is a particular trial related to the Chagas disease or to the Chagas cardiomyopathy. And the trial was made in a very simple way by randomizing patients with Chagas disease, which very importantly was diagnosed by positive serological test to the Trypanosoma cruzi, which is the one which causes the Chagas disease. And the patients were randomized to placebo, to this benzodiazepine drug given at 300 milligrams per day. And the follow-up was for 21 days, and the end of treatment was 6 months. Now, the Chagas disease may be not very important in your country, like in my country, although with all this immigration we can start to see some of the Chagas patients. But it is important to say that it is the third commonest parasitic disease globally, is the most common form of non-ischemic cardiomyopathy in Latin America, and in Latin America by between 5 to 7 millions are infected. So in some part of the world, this is a real serious problem. It is due to the Trypanosoma cruzi, and even a very low level of the presence of the Trypanosoma may be an important factor. And what has to be emphasized is that in the benefit trial, patients were kept in the very early stage of the disease. As you can see, they were in class 1, and they almost have a normal ejection fraction, but they have a very clear evidence of the Trypanosoma in their blood, and that was tested at least by two blood testing. And unfortunately, once again, I have to say, this was a neutral trial showing that this drug death, sustained ventricular tachycardia, which is one of the problems of the Chagas disease, the need of using pacemaker, the need of cardiac transplantation, stroke, and so on. So again, not a very positive results, showing that these drugs did not significantly reduce the clinical progression, despite being successful in reducing the PCR blood and the trypanosoma detection in the blood. The drug was very well tolerated, but unfortunately with no clinical effect. And then there was another very interesting studies looking at sleep disorders in a patient with heart failure. And as you know, between 50 to 65% of the patients with heart failure suffer from sleep disorder, breathing. Either they suffer of obstructive sleep apnea or the central sleep apnea, which may manifest with Cheyne-Stokes respiration. We know that both these events are resulting in tissue hypoxia, and that could be not ideal for a patient with heart failure. So it was a very logical study to be done. It was also very logical because there were previous small or uncontrolled studies showing that by improving these sleep disorders resulted in improvements of surrogate markers of heart failure. Also, there was a post-hoc data from a group using the CPAP, which showed a possible improvement in mortality in a patient with heart failure and with an ejection fraction below 40%. So a study was set up using a new non-invasive ventilatory therapy that supports the inspiration when the breathing amplitude is reduced and also ensures sufficient respiration when the respiratory effort is absent. And this is how the device works. And these are the baseline type of patients. And you can see the two groups were very well matched. And once again, unfortunately, there was no positive data. And actually, if something, it seems that the use of this particular device, and that was very surprising and not at all expected, could even make the situation worse. And this is particularly important because the death of any cause and also the cardiovascular death were really made worse by reducing this sleeping breathing. So, in conclusions, I showed to you several theoretically very important and interesting ideas which didn't came through the clinical trial. And this is the main message that I would like to put to you, that improving heart failure, it is not an easy job. We did have several improvements through the years, but now it seems and it is difficult to do better than what we have done. I must say I'm quite surprised about the breathing study, and because I thought was really a very good idea, but also all of this is stressing how important it is to test the ideas in proper clinical trial. And the last slide, Professor Pinto invited you to Rome, and of course I also invite you to Rome. I'm from Italy. I can assure you that Rome is a lovely city and is ready to welcome you. But also Florence is a very good city, and you might consider to come in Florence in May for the Heart Failure Association, and I'm sure you will have a lot of more on heart failure there. Thank you very much for your attention.